A warm good evening to each one of you, and a special good morning to you, sir. I once again welcome you all to our 6th International Alumni Webinar conducted by the Research and Postgraduate Department of Psychology, Union Christian College, Aluva, as part of our Centenary Year celebration. For an auspicious beginning, let us have a few moments of silent prayer. Today, we have with us a special guest, Dr. Sonny Joseph of batch 1967 to 71, who is a clinical psychologist and psychiatrist at Orlando, Florida, USA. He is going to talk to us on the topic Systematic Approach to the Psychopharmacological Management of Common Psychiatric Disorders Based on Symptoms. We will now be moving on to the session. I would like to remind the participants that they should post their questions in the comment section for the speaker to respond. You may post your questions while the speaker is speaking and need not wait till the end of the session. You will also find a link to the feedback form in the comment section. Kindly fill in the form and submit to ensure that you receive your e-certificates. First, I invite Ms. Saina Susan Abraham, Head of the Department, to deliver the welcome address.
Good afternoon. A very warm welcome to the Research and Postgraduate Department of Psychology, Union Christian College. This is the 6th live webinar by the alumnus of the department in connection with the Centenary Celebrations of our college. It's my pride privilege to welcome all of you to this webinar. Let me welcome the participants, a mixed group of students, research scholars, faculty members, academicians, and practitioners of psychology, and also from other fields who are interested in psychology. Today we have a very distinguished alumni as the resource person, Dr. Sonny Joseph. He was a member of 1967-71 batch of graduation psychology in UC College. So he is one among the senior most alumni of the department. A very warm welcome to you, sir. His unique distinction also is that he is a clinical psychologist as well as a psychiatrist. So, and he has been trained in India and abroad. So I can say he has traveled the breadth of the subject as well as the world. So it would be a rare opportunity, a rare privilege to interact with the stalwart of our field, who has rich experience, a long experience in our field. So indeed a privilege to have you here, sir. And I hope all the participants would make this opportunity, make the best of this opportunity to interact with you. And I wish the participants and the resource person all the best, and welcome once again to the Department of Psychology and a very fruitful session ahead. Thank you.
Thank you, Ms. Now, I invite Dr. Sina M. Matai, coordinator for this program, to introduce our speaker.
A warm good evening to one and all. Today we have a very renowned resource person who is from Florida, USA. So it's an honor for me to introduce Dr. Sonny Joseph. He passed out from our department in the year 1971. And when I went through his resume, I found that he excelled not only in academics but also in sports and arts, and his participation was that made me so happy that he was a member in the university hockey team, tennis team, badminton, volleyball, football, I don't know, and what not. And he was also into the college arts club activities. He had a very enriching experience from Union Christian College, and from where he joined Kerala University for his masters and passed out from there in 1973. Then he joined the University of Ottawa for his PhD in clinical psychology, and he had the opportunity to meet Professor Maurer, a leading learning theorist at his home in 1974. In 1981, he took his master's in public health from Michigan Institute of Technology in Health Administration, and later on from Harvard University in preventive medicine. And it is at this time that he got an opportunity to interact with Professor B.F. Skinner, who was a professor at the Department of Psychology, Harvard University. And he'll be sharing with us his photo with B.F. Skinner. He'll share shortly, that will be shared. Then, unlike us, no, he joined for MBBS from University Jerus, Mexico, and took MD in 1990 from Jefferson Medical College, Philadelphia. He took his training, later on joined Royal Ottawa Hospital and Thomas Jefferson University Hospital for full-time training in clinical psychology and psychiatry respectively. Then he served as a clinical director at Mental Health Clinic, Barrow, Alaska during 1978 to 80. Then he was a staff clinical psychologist in Mental Health Clinic, Ohio. And 1990 onwards, he was doing solo private practice with primary focus on psychopharmacological management of mental disorders in Orlando, Florida. He has 4 international publications in reputed international journals like the American Journal of Applied Psychology, and he also finds time for his passion in football, music, movies, and preventive medicine. He is refereeing and managing a soccer group since 1996, encouraging non-contact civilized play for aerobic fitness and writing to promote civilized football. And I'm very sure that we'll definitely have a very enriching and productive time interacting with Dr. Sonny Joseph. And on behalf of the department, sir, I invite you for delivering the talk. Thank you.
Hello. Good evening. Our evening, good evening to everybody. അപ്പോൾ ഞാൻ UC കോളേജിൽ വന്നതിൻ്റെ ചെറിയൊരു ഹിസ്റ്ററി പറയാം. എനിക്ക് സൈക്കോളജിയിൽ ഭയങ്കര ഒരു ഇൻഹറൻ്റ് ഇൻട്രസ്റ്റ് ചെറുപ്പത്തിലേ തന്നെ ഉണ്ടായിരുന്നു. അപ്പോൾ പ്രീ ഡിഗ്രിക്ക് പഠിക്കുമ്പോൾ തന്നെ ഈ പാവ്ലോവിൻ്റെ എക്സ്പെരിമെൻസും ഒക്കെ വായിച്ച് അങ്ങനെ ഒരു ശരിയായിട്ടുള്ളൊരു ഇൻട്രസ്റ്റ് അന്ന് എന്തോ കാരണം കൊണ്ട് അങ്ങനെ ഒരു ഇൻട്രസ്റ്റ് വന്നു. അപ്പോൾ പ്രീ ഡിഗ്രി കഴിഞ്ഞപ്പോൾ ഞാൻ എൻ്റെ അപ്പച്ചനോട് പറഞ്ഞ് എനിക്ക് സൈക്കോളജി പഠിക്കണം. അപ്പോൾ സൈക്കോളജി അന്ന് UC കോളേജിൽ മാത്രമേ ഉള്ളൂ. പക്ഷേ അപ്പച്ചന് അന്ന് അതൊരു വിശ്വാസമായില്ല. കാരണം അന്ന് നമുക്ക് പൈസ കൊടുത്ത് മെഡിക്കൽ കോളേജിൽ സീറ്റ് നമുക്ക് നേരത്തെ തന്നെ മേടിച്ചു വയ്ക്കാം. അപ്പം അന്നൊരു സീറ്റ് ആലപ്പുഴ മെഡിക്കൽ കോളേജിൽ അന്ന് പൈസ കൊടുത്ത് മേടിച്ചു വയ്ക്കുന്ന ഒരു സമ്പ്രദായം ഉണ്ടായിരുന്നു. അപ്പോൾ അന്നൊരു സീറ്റ് ഇങ്ങനെ മേടിച്ചിട്ടിരിക്കുകയാണ്. അപ്പോൾ അപ്പച്ചൻ എന്നോട് നീ മെഡിസിന് പോയാൽ മതി, നീ സൈക്കോളജിയിൽ അന്ന് സൈക്കോളജിയിൽ പോയിട്ടൊരു സ്കോപ്പ് എന്ന് പറയാനായിട്ട് ഞാൻ പറയുന്നത് 67 സമയത്താണ്. പക്ഷേ എനിക്ക് എന്ത് പറഞ്ഞാലും എനിക്ക് സൈക്കോളജി തന്നെ പഠിക്കണം എന്നുള്ളൊരാഗ്രഹം. അപ്പം എന്നെയും കൊണ്ട് അപ്പച്ചൻ ഈ അഡ്മിഷന് മുമ്പായിട്ട് അലക്സാണ്ടർ സാറിൻ്റെ അടുത്ത് പോയി. അപ്പോൾ അപ്പച്ചൻ സാറിനോട് ചോദിച്ചു, സാറേ ഇവൻ സൈക്കോളജി പഠിച്ചുകൊണ്ട് വല്ല ഗുണം ഉണ്ടാവോ ഇവനിതും പറഞ്ഞുകൊണ്ട് നടക്കുകയാണെന്ന് പറഞ്ഞിട്ടുണ്ട്. അപ്പോൾ സാറ് പറഞ്ഞു, അത് ഓരോരുത്തരുടെ പരിശ്രമവും ഓരോരുത്തരുടെ അച്ചീവ് ചെയ്യുന്ന ലെവൽ അനുസരിച്ചിരിക്കും. ഇപ്പോൾ സൈക്കോളജി പഠിക്കുകയാണെന്നുണ്ടെങ്കിൽ ചുരുങ്ങിയത് മാസ്റ്റേഴ്സ് ഇല്ലെങ്കിലും പോകണം. ഏറ്റവും നല്ലത് ഒരു PhD ലെവലിൽ പോയി കഴിഞ്ഞാൽ അതിന് ഗുണമുണ്ടാവും. അപ്പോൾ സണ്ണിക്ക് ഇഷ്ടമുള്ളത് പഠിക്കട്ടെ എന്ന് സാറ് പറഞ്ഞു. ബൈ ദ വേ, മലയാളത്തിൽ മലയാളം മനസ്സിലാവാത്ത മലയാളികളാണെന്നുള്ള ഒരു ഉദ്ദേശത്തിലൂടെയാണ് ഞാൻ മലയാളത്തിൽ പറയുന്നത്. അപ്പോൾ ആർക്കെങ്കിലും ഇംഗ്ലീഷിൽ പറയണമെന്നുണ്ടെങ്കിൽ ഇംഗ്ലീഷിൽ ഞാൻ പറയാം. പക്ഷേ അപ്പം അങ്ങനെ ഒരു തീരുമാനം എടുത്തു, UC കോളേജിൽ സൈക്കോളജി തന്നെ പഠിക്കാമെന്ന് വിചാരിച്ചു. അപ്പം എനിക്ക് അന്നേരം തന്നെ മനസ്സിലായി, നമ്മൾ സൈക്കോളജിയിൽ എടുത്തു കഴിഞ്ഞാൽ അതിൻ്റെ മാക്സിമം പ്രൊഫഷണൽ ലെവൽ, അതൊരു PhD ലെവലിലെങ്കിലും പോകണം. അപ്പം അന്ന് സ്കിന്നർ ഹോസ്റ്റലിലാണ് ആദ്യം താമസിക്കുന്നത്. അലക്സാണ്ടർ സാറിൻ്റെ വീട് സ്കിന്നർ ഹോസ്റ്റലിൻ്റെ തൊട്ടടുത്തുള്ള ഒരു വീട്ടിലാണ്, UC കോളേജിൻ്റെ തന്നെ ക്യാമ്പസിൽ. തൊട്ടടുത്തെന്ന് വെച്ച് കഴിഞ്ഞാൽ അതും ആ ക്യാമ്പസ്, അതേ ക്യാമ്പസിൽ തന്നെയുള്ളൊരു വീട്. ആൻഡ് UC കോളേജിൻ്റെ അല്ല സ്കിന്നർ ഹോസ്റ്റലിൻ്റെ വാർഡനായിരുന്നു സാറ്. അപ്പോൾ വളരെ ഒരു ക്ലോസ് ഇൻ്ററാക്ഷൻ ആയിരുന്നു സാറായിട്ട് അന്ന് ഉണ്ടായിരുന്നത്. പിന്നെ സാറിൻ്റെ ഒരു ടീച്ചിങ് ഫോക്കസ് എന്ന് പറഞ്ഞാൽ അന്ന് ഒരു ക്ലിനിക്കൽ ഫോക്കസ് ആയിരുന്നു. കാരണം സാറ് ഇപ്പം രോഗികളെ കണ്ട് പഠിപ്പിക്കുന്ന ഒരു 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 ശരിയായിട്ടുള്ള ഒരു ക്ലിനീഷ്യൻ പ്രൊഫസർ സയൻറ്റിസ്റ്റ് എന്ന് വേണമെങ്കിൽ പറയാം. അപ്പം അന്ന് എനിക്ക് തോന്നുന്നു സാർ 1-2 PhD സ്റ്റുഡൻസിനെ കേരള യൂണിവേഴ്സിറ്റിയുടെ കീഴിൽ സൂപ്പർവൈസ് ചെയ്യുന്നുണ്ടായിരുന്നു. എനിക്ക് പേരൊക്കെ മറന്നുപോയി. പക്ഷേ അപ്പോൾ സാറിൻ്റെ പഠിത്തം എപ്പോഴും ഒരു ക്ലിനിക്കൽ ഫോക്കസ് ആയിരുന്നു. അപ്പം എൻ്റെ ഒരു താല്പര്യവും അത് തന്നെയായിരുന്നു. അപ്പോൾ സാറ് ഇടയ്ക്കിടയ്ക്ക് ഈ ഹിപ്നോസിസ് സെഷൻസ് ക്ലാസ്സിൽ ശരിയായിട്ടുള്ള പേഷ്യൻസിനെ കൊണ്ടുവന്ന് കാണിച്ചു കൊടുക്കും, അല്ലെങ്കിൽ പേഷ്യൻസിനെ ഇൻ്റർവ്യൂ ചെയ്യുന്നത്. പിന്നെ ചില ഈ സൈക്കോളജിക്കൽ ടെസ്റ്റുകളിൽ നിന്ന് നമുക്ക് എങ്ങനെ ഓരോ രോഗികളുടെ പാത്തോളജി എങ്ങനെ മനസ്സിലാക്കാം, അതായത് ഇപ്പോൾ തീമാറ്റിക് പെർസെപ്ഷൻ ടെസ്റ്റ്, TAT എന്ന് പറയുന്ന ടെസ്റ്റ്, അല്ലെങ്കിൽ ഡ്രോ എ പേഴ്സൺ, അല്ലെങ്കിൽ റോഷാർക്ക് കുറച്ചൊക്കെ. അപ്പോൾ വേറൊരു കാര്യം സാർ, അപ്പോൾ ഇന്നാണ് അതിൻ്റെ സിഗ്നിഫിക്കൻസ് മനസ്സിലാവുന്നത്. ഇപ്പം എല്ലാ സ്റ്റുഡൻസിനോടും ഒരു ഡ്രോ എ പേഴ്സൺ ടെസ്റ്റ് ഒരു വരയ്ക്കാൻ പറയും. ആദ്യം ഒരു ആണിൻ്റെ പടം, പിന്നെ ഒരു പെണ്ണിൻ്റെ പടം. അപ്പോൾ അത് നമ്മളൊരു സ്റ്റിക്ക് ഡ്രോയിങ് പോലെ ഒരു കടലാസിൽ വരച്ച് സാറിന് കൊടുക്കും.
ഹലോ സാറേ. ഹലോ, എക്സ്ക്യൂസ് മീ സർ.
Okay.
Sir, can you talk in English, sir?
Oh, sure. Okay. So he used to ask us to draw these pictures, simple, skeletal type of pictures, outline pictures of a male and a female. And now I know he was trying to figure the students out. Is this a problem student? So anyway, I remember he used to have us hold, I think, monthly presentations. So a student has to pick a topic and give an in-depth presentation on that particular topic. And I also remember that he would take us to a hospital each year. I think we went to Trichur Mental Hospital at that time and went inside and saw the wards and saw the patients walking around. So in any case, it was a great introduction to not only psychology, but also the clinical psychology. So unfortunately, there was no master's program at that time at UC College. And the other aspects of my experience at UC College, I have to tell you, not because UC College is celebrating its centennial year, but this is my true belief, because I was fortunate enough to attend many top universities in the world. I shouldn't say many, but at least a couple of top universities in the world. By the way, there was just one clarification. I attended Massachusetts Institute of Technology, not Michigan. Massachusetts Institute of Technology is a university in Boston, in Massachusetts. It was a combined program with Harvard, the master's in public health with concentration in mental health and preventive medicine, and which is where I had the opportunity to take a picture with Dr. Skinner, who was still teaching there as an emeritus professor. I think I've lost my train of thought. Let me try to get back. So what I was saying is that, so I knew that I had to go through the master's. There was no psychology, the master's program at UC College. So I wish there was, because UC College gave me so much opportunities. It had a residential system then, and UC College used to attract students from all over the state. And whereas now I understand that it's more of a local college because uh, they stopped the residential system. What I heard was sometimes in the late 70s because of political strikes and students taking on the causes of political parties and causing problems in the campus. So they had difficulty in managing the residential campuses. There were like 5 different residential facilities at UC, and it became very difficult to manage the students. And the ladies had a separate residential. I think they had 2 hostels right outside the campus, whereas the 5 hostels inside the campus were for men. And we had a lot of fun there because I used to, in my case, took lots of interest in sports. I was able to excel in many sports, and I mentioned that in my resume. And I don't need to go too much into details, but I was able to form great friendships there that I still maintain. So whenever I go to visit India, I would make it a point to visit UC College, walk around the campus. But usually I come during the summertime, so I didn't have an opportunity to see the students or the professors. They would be on vacation during that time. But I still would go to UC College. UC College offered the greatest opportunities among all the universities that I attended, including the University of Ottawa in Canada, which, by the way, is an excellent program, especially for clinical PhD. The medicine at the University of Juarez in Mexico, the Harvard campus where I stayed in their residences as a student, MIT, where I did half of my master's in public health program, Jefferson Medical College. All these established universities, none of them offered the kind of overall experience for the growth of a young student that UC offered. So when I went to University of Kerala, Karyavattam University Center for their master's, because that was I think the only program that had the master's there, although they had distinguished professors there. The head of the department was Dr. George, E.I. George, who was a student of Dr. Eysenck at the University of London, where he did his PhD. So we had distinguished professors like we had at UC College. Well, so one thing, I don't know if the newer students know this, but Dr. Alexander took his PhD from Princeton University, which is one of the top universities in the world, where Dr. Tompkins, who was a very established figure in clinical psychology then, was the supervisor for Dr. Alexander's PhD thesis. Just a little interesting information. And so UC College is always in my mind. And when I was a student at the University of Kerala, almost daily I had dreams of being back at UC College. I was thinking if UC College would ever offer a master's, I would come back to UC College just to be there and get another master's degree, because I just liked the life there. Just to give you a very short example, I was very much into field hockey because I liked the ball control that you can use with a stick. So we had hockey practice every evening From about 4 to 5 were the time allotted for the girls, and after 5, boys come onto the field and they practice and they play. And because I was so involved in that game, um, and I was also a team member for their tennis team, so I would go in the morning, wake up in the morning to play tennis. And this is somebody who still um, has extreme difficulty in waking up in the morning. I just didn't. I had such a hard time. In fact, I was kicked out of the seminary for having difficulty waking up in the morning for the 5:30 mass. So, but I would wake up for tennis practice, and we would go practice tennis in the morning, go to college. And at that time, there were no exams every month that would count. So we could have so much fun during the school year and then catch up at the end. They call it study holidays. I don't know if that system is still there. So they would give a month or two for study holidays. So at that time, there are not many activities in sports. You would sit and study day and night and take the exam, and I've usually done well. And in fact, I used to, I don't know if you remember, Kunyikrishnan was very well known then because his notes were very thorough. So we would all try to, and he was very generous in sharing his notes. He was a senior student. And I heard that he later on went to Calicut and became the professor. I lost touch with him. And Gopakumar, my close friend then, I used to share his notes, especially some of the lab notes. I'm very grateful to him still for him generously sharing that with me. So one other, when I think of Gopakumar was the art secretary then. And I was into music, and I adored Yeshudas. That was the time when songs like Sorgabutri, Kayampu, all those very melodious songs came out. So I wanted to meet Yeshudas, and he was the art secretary. And Yeshudas held a meeting at Kalapavan in Ernakulam to a meeting of all the art secretaries in that district, Ernakulam, in that surrounding areas. So Jeshudas wanted to encourage music awareness and education among young students. So Jeshudas and Father Abel held a meeting at Kalapavan, and Gopakumar, since he was my close friend, he's still my close friend. I lost touch with him lately, but so he took me with him for the arts meeting, and I was able to see Yeshudas in a small room up close, and that was one of the highlights of my experience there. So, but anyway, so I went on to do the doctorate and all those. That was mentioned. So let me go to the topic that I am very familiar with. So now my professional identity is as a psychiatrist, primarily focusing on complex psychopharmacology. So the topic is how to, this is a very vast topic, so I can only just cover some general ideas. And so if people have any specific questions, whether it is simple or complex management of psychiatric disorders, feel free to ask those questions so I can be a little more focused and a little more educational and serve your needs. Now, my experience as a practicing clinician, both in clinical psychology and psychiatry, has been in the United States. However, even as early as 40 years ago, my people who knew me, my friends, some of my classmates, their relatives, or their friends, if they had an issue, they would either write letters at that time or contact me on the phone, or and get my input as to how to treat problems of people in Kerala. So I'm a little bit familiar with the mental health situation in Kerala. Overall, my observation has been, mental illnesses, mental difficulties are everywhere. There is nothing unique to Kerala. There is nothing unique to the United States or the Western world. The human mind is very, very similar. Now, there are faith-based practices that are different. For instance, in Kerala, there is a lot more emphasis on alternative approaches to allopathic medicine. By allopathic medicine is my specialty, but in Kerala, obviously, there is Ayurvedic treatment, homeopathic treatment, and faith-based healing. So you go to temples or churches. In Malayalam, Badavulpikya, Budam, Kaivisham. So there's a lot more emphasis on the belief systems, maybe religious-based cure, and that might work in some people, and there is really nothing wrong with that. But in my experience, both having studied psychology and clinical psychology at the very highest levels of the training that you can get, plus the medicine, and then specializing in psychiatry. Am I still? Oh, okay. Then in psychiatry, I believe that I'm able to give a pretty good perspective as to how we can best approach the treatment of mental health. And my belief is, and this is a quotation that I had in my 2 books that I published on the psychopharmacological management of mental disorders. Even Freud, who was the father of psychoanalysis, who used, as you probably know, free association and dream analysis. Those were the tools of psychoanalysis. Those were the tools that he employed to get to the dynamics of the psychopathology of a person. And even he believed at that time, and we were talking about 1930s and 40s, when he truly believed that the psychopathology is based on the brain pathology, but there were no effective medicines at that time. Even the first antipsychotic, which is chlorpromazine, I think the brand name in India is Largactil, was introduced in the early 50s, and from then onwards there were other traditional antipsychotics as well as antidepressants. Initially, there was the monoamine oxidase inhibitors like phenelzine, tranylcypromine, and then there were tricyclic antidepressants, like the most well-known is imipramine, and then the serotonin enhancing antidepressants. Then there are so many varieties of that: norepinephrine enhancing antidepressants, dopamine enhancing antidepressants, and a mix of all of those things. So my belief is that the ideal approach is a combination of psychotherapy and in many cases medications. And because essentially the theory is that psychotherapy can eventually alter the brain dynamics. Um, and although it might take time. Now, that may be true, but there are many cases that you don't really have the time to wait for that to occur. And the example I would use is that if somebody has a bad infection, it's too late to be hygienic. You got to take antibiotics or antivirals or anti-fever medications or anti-inflammatory medications to contain the inflammation and the fever and the infectious process and to eliminate the bacteria or the virus. So, but once you clear the system of the acute illness, then you can be more proactive or preventive and follow good hygiene to the extent that is possible. So, because psychotherapy takes a lot of time, many therapists, many counselors would prefer to get the patient on medications to contain the acute symptoms so that they become more receptive to benefit from the insights that they gain from therapy. So the purpose of the therapy is to be able to learn better coping mechanisms by using different approaches. There could be cognitive behavioral, supportive, analytical, rational emotive, self-actualization therapy. Obviously, you know more than me because you're current in your field. I'm not current in that field, but there are many approaches to the psychotherapy, but essentially they say what matters more is that rapport that you feel a connection with your therapist, and the tone of voice and the feel that you get more than the technique is curative, and the supportive and the analytical process. And the way I approach in picking a medicine, because how do you say a patient comes with depressive symptoms, how do you pick a medicine to try first? Obviously, the goal of the doctor is to get the patient better as soon as possible. So when a patient comes in, obviously my goal, or any psychiatrist or any doctor's goal, whether it is in mental health or any other field, is to get the patient better as soon as possible and symptom free. So the doctor wants to pick in his or her judgment the best medicine that would get the job done fast. So how do you pick that medicine? So a patient comes with say, depression, but you want to know the specific symptoms of depression. So depressive symptoms could be excessive crying or being overly sensitive emotionally, or overly worried about things. So there are some people who are by nature what we call worrywarts or warriors. So the questions I would ask, do you get depressed to the point of becoming tearful frequently? Obviously, people have the right to cry for very unfortunate events or losses in life, and we don't consider that as a sign of depression. Whereas if somebody becomes tearful for very simple reasons, then it begins to affect their judgment. So it's good to be sensitive, but if you don't want to be oversensitive, because when you're oversensitive, it affects your own state of mind, and it affects other people around you. If you're, and the same thing for being over perceptive, it's good to be perceptive. You want to be able to perceive things as well as you can. But if you're over perceptive, that then goes into becoming a paranoid tendency, because people who are over perceptive, they see things that are not really there, and that's a very common problem in Kerala, because a lot of marital difficulties and intrafamilial problems occur because of that, and it's very difficult to diagnose because they have a reason to justify their distrust or suspiciousness. So what you do then is to look at the big picture, because if you ask the patient for why are you crying, or why don't you like that person, or why do you think that your husband or wife is not not being truthful, there is always a reason. So looking for a reason is not enough. You have to look beyond and look at the big picture. So that's why, in my experience, I prefer to have family members present, because they give a better picture of a person's, um, because they have a lot more personal experience dealing with that person, and they suffer the consequences of a person's oversensitivity or over perceptiveness, um, and they are able to get a better picture for you, a lot better than some of the psychological tests. Obviously, there are psychological tests for TAT. You look at the word associations. For instance, in schizophrenia, the major defect is in their thought processes, and those thought processes reveal themselves in psychological tests. For instance, word associations, they would give strange associations to a word association test, or if you ask them for to come up with a story based on a picture, which is TAT, the story has a lot of times a bizarre quality. But even better than that is to get history from family members, and that way you can make a fairly rapid diagnosis. And otherwise, the diagnosis itself will take quite a bit of time. And besides, in the field of psychiatry and psychology, there are no blood tests or X-rays to make a diagnosis. So it all depends on the analysis of the doctor. And in my experience, if I could say this myself, my training and experience in clinical psychology has tremendously helped me in making a diagnosis in psychiatry, because that's an enormous breadth of knowledge that that is in my head, and I don't realize it. That comes in when I see a patient, um, and I did not, do these things on purpose. In other words, when I was doing my bachelor's in psychology, I was thinking I would be very, very happy if I could just get a PhD in clinical psychology and practice as a psychologist. I would have been very happy. There was no thought of going into medicine at that time at all, zero. And so the medicine idea came only after I got here and after I was working as a clinical psychologist for about 3 years. So that was not planned, and because there is really no need to go through a PhD in psychology to become a psychiatrist. But looking back, I think that psychology experience at the highest levels that you can get significantly helped me in excelling as a psychiatrist. And from what I hear from the patients in the United States, that is the impression that I have, that I'm doing very well in terms of figuring out their problems and helping them. I would say about 99%. I don't look at my ratings, because there are certain times that I have to disappoint patients if they ask for medicines that are addictive. I will not prescribe that for them. If I don't feel medicines, they need those medicines, I'm not going to prescribe to them. I will explain to them why it's not in your best interest, and 99% of the people have no problems. But in any case, so when a patient comes in, so you ask for the presenting symptoms such as, say, somebody is overly sensitive, overly emotional, then you like to prescribe medicines that are more in the serotonin um, enhancing category, like fluoxetine or escitalopram. I don't know the Indian names. And just for the students, all medicines have two names. One is a brand name that the company gives, and the other is a generic or chemical name. So whenever you talk about a medication, it is better to give the chemical name, because that's universal, whether it is United States or Europe or India. The chemical name is the same. So fluoxetine is here in the US, it is Prozac. I don't know the brand name in the in India. Now, having this opportunity, um, if there are colleagues, friends, I would like Dr. Sina to share my email address and my cell number to my colleagues and doctors and psychologists there. If they have a case, I'll be happy to give some guidance on the phone or email. So feel free to share my number, because this is something I like, I enjoy doing. I enjoy figuring out people and trying to help them in a clinical context, but not outside of a clinical context. I'm probably one of the most gullible people that you ever meet, because my boundaries, my persona changes. In a technical clinical situation, I become very focused on their mental processes. I look for every word that they say, whereas in a social context, I'm just a shy, quiet type of person. But in any case, so if somebody comes in that sensitive, worrying, nervous symptoms, then you tend to prefer the serotonin medications. Whereas if they come in with apathy, no energy, no drive, no motivation, they've lost interest in activities that they used to enjoy. So you want to give them some energizing medicines, such as bupropion, for instance, or bupropion combined with a very low dose of this medicine called aripiprazole, 2 milligram. And these are not addictive medicines. So, so generally speaking, there are certain profiles that you can come up with to guide the doctor in prescribing the medicine to maximize their rate of response. Um, and that refers to, now I mean, this is a very vast topic. When the patients come in with depression, it could be the depressive phase of a manic depressive condition or bipolar disorder, or it could be the prodromal phase of schizophrenia, because typically the classical schizophrenia begins in their late teens, and initially they present as uh, losing interest. A student who was very studious and social and excelling in the studies begins to slowly withdraw. Their interest become very introverted. They become more interested in poetry, for instance, or computer games. Very, very artistic type of interests, or reading things, or drawing. So their external interests turn more inward, and they spend more time by themselves, and they avoid too many social contacts, avoid friends. So there is a depressive element to how the early stages of, for instance, schizophrenia presents itself, and that's very hard to differentiate at that point. So the diagnosis, because I mentioned that there is no blood test or X-rays to tell us exactly what's going on in the mind, you're trying to diagnose the neurochemistry from outside by just analyzing the symptoms. And so the psychiatric diagnosis is usually an evolving process. So what you think as initially just some anxiety or some situational depression or some mild chronic depression can eventually turn out to be a schizophrenia or bipolar disorders, because you never know until the first manic episode occurs whether or not that you can diagnose this patient as a bipolar and put that patient on a mood balancer, and then psychotherapy counseling to go along with it. So definitely then the psychotherapy helps patients become more introspective. So when there are relapses in their symptoms, they are able to kind of pick it up themselves. Otherwise, it's very, very difficult to get a manic patient into treatment because they have no insight. The same thing with people who are paranoid, because they believe that it is the other people around them that are causing them problems, and they refuse to take treatment. So it's important, once you get the um, patient symptoms under control using medications rapidly, to get them immediately into therapy so that they can develop that self awareness, which is very protective for them then to develop that introspective ability to almost see that they are beginning to experience a relapse and call the doctor and maybe adjust the medications or call the psychologist and let the psychologist intervene and reassure the patient and encourage the patient to continue therapy or to go see the medical doctor to adjust the medications. And then so then the other category that, well, here in the United States, we see more attention hyperactivity problems. They call ADHD. And actually, the ADHD problems are very prevalent in India. It's just that the treatments are not available. When I was looking at the formulary of medications in India, there are only very few. I think there was just one medicine when I looked at it last time for ADHD. I thought it was Ritalin or methylphenidate. I don't know if amphetamine salts are available for students to, because there are many students who have difficulty staying focused on their studies. They get very distracted after about an hour, half an hour of focusing on study materials. And there is so much enormous pressure by Indian parents for their students to excel in their studies, because that's the way for them to achieve a good standard of living, education. And I think more than here in the US, I noticed the trend that Indian parents put so much pressure on their children to excel in their studies, because only people who get the highest grades are then able to obtain admissions to higher training and admissions to professional schools. There is so tremendous, the children are under tremendous stress, perhaps more than when I was a student, although I should say in psychology there was really not that much pressure, but people who are wanting to go into medicine or engineering or other, maybe computer science, there may be a lot more pressure. But I didn't experience then, but I've heard from reports recently that the parents put tremendous stress on their students, and there are students who cannot cope with it or don't have the inherent abilities to live up to the parental expectations that causes so much stress and frustration. But the ADHD could be a factor, but that's probably underestimated. And the ADHD medicines are very controlled medicines, so they are not medicines that you can just prescribe. It can cause other problems of dependence and tolerance and resistance. So when we prescribe it here, it is at very low dosages for only as needed. And one of my friends is asking me to send the link, but I think it's too late, so I'll tell him later. Now, this is Joby, who was a student who went to UC College, who actually is now a guitarist for Yesudas here in the United States, but I don't know how to manipulate and send him the link. But in any case, so in the US, about 60-70% of the patients that come to my clinic are ADHD patients. I wouldn't call them patients, but for lack of a better word, I have to use the word patient. I tell them you're not really a patient. You just need some support for your focusing. And that's not only for students, but also for people who work, especially in areas that require lots of concentration. For example, computer-intensive work. How can you sit for 7-8 hours? And most people are able to, but there are many who cannot maintain that focus for that length of time. And especially those who have ADD, ADHD, they have difficulty maintaining that focus, or they get what's known as fidgeting, or a simpler word would be restlessness. They want to, tap or pace around and tap their legs, and so it becomes a stress for them to maintain that focus. And the ADHD medicines at low dosages, and only at times that they need it, significantly improve their performance. So, for instance, students here that are used to getting C or B grades would, once they start this medicine, they would get an A grade. So this is not a placebo effect, I know for sure, because when you are sensitive to patients, when you have that empathy with the patient, and you clearly know if there is a significant improvement in their functioning at the second or the third visit, with using the right medicines. And sometimes it may take 3 or 4 visits to come to the right medicine. So you always tell patients there is a little bit of a trial and error involved, because no medicine works for everyone. So it's up to the patient to be able to go back to the doctor and tell the doctor, look, I tried this little medicine, I'm doing better, or I had this side effect, this other side effect that is not going away. That gives the doctor an opportunity to adjust the medicine or change the medicine. So in some cases, patients respond the very first time. And in some cases, you have to try multiple medications to find the right medicine. And one of the most difficult areas to treat, not because it is psychopharmacologically difficult, but it's a strain on the doctor, is any schizophrenias, because you see a patient, a young patient typically, the parents bring him, and how can you tell a parent that your son has beginnings of schizophrenia? So I avoid using that phrase. I tell them this is a little bit of depression. Hopefully he will get over it. But I treat him as if it is schizophrenia. And I tell the patients, look, doctors use the same medicine for different purposes. So this medicine can be used for bipolar disorders. I mean, people hear the word bipolar or manic depression or schizophrenia, they are scared. Parents are scared. And some, in rare cases, they get mad at the doctor. So, doctors try to avoid that diagnosis, even if they have a serious suspicion that that is the diagnosis. But you tell them, well, it's a little depression, try this medicine and see how it works. And then you slowly introduce the diagnosis as a possibility, because you don't want to upset the parents, and but you want the patients to get better also. So that's one of the difficult areas, not for only for a psychiatrist, but for a therapist, because for a psychologist, even the psychologist, even if they understand this is the beginnings, or this is a process of schizophrenia, the patients end up typically blaming others, and how can you support that? Although one of the therapists' job is to be very supportive to the patient, but you can't be supportive if the patient is totally irrational. So how can you get the patient to see the reality without alienating the patient, without affecting the rapport? It's a very difficult process. So the therapist get frustrated. I just wrote some notes here. So among the biological approaches, psychopharmacology is by far the most predominant approach. There are other approaches like ECT, TMS, or transcranial magnetic stimulation, vagus nerve stimulation, but those techniques are not commonly used, although ECT in very severe depressions help, especially if patients are sensitive to medication side effects. And so I don't know if we have any questions. Let me see, what time is it? Okay, it's almost 9:30. So if you have any questions, I could be a little more focused on, and I'll be more specific as to the medicines and the dosages, if that's what the questionnaire wants me to explain. Any questions so far, or may I just continue with whatever comes to my mind?
Hello, sir. A few questions have arrived, so I will say it to you. The first question is from Wasim. The question is, how can we treat bipolar disorder?
Bipolar disorders are treated using mood stabilizers. There is a group of medicines called mood balancers. The purpose is to blunt the manic episodes as well as the depressive episodes. Both extreme depression and mania, although they are called affective disorders meaning having to do with your emotions. They are not thinking disorders. That would be more like a psychosis or schizotypal personality disorder or schizoaffective disorders or schizophrenia. However, in the extreme stages of depression or mania, they affect the judgment of the person. They affect the thinking of the person. So if somebody is extremely emotional, the mental dynamics doesn't stay in the emotional spectrum. It bleeds into the thinking spectrum. It totally affects their judgment, which is their thinking. They become irrational in their thinking, which is when they do crazy things, like trying to take their lives, because they're not thinking right. Although the primary diagnosis may be the depression. There are different types of bipolar disorder. There is a classical bipolar disorders that would be a manic phase lasting 3-4 months, alternating with a normal period, and then going into a depression. And there is no guarantee the manic phase would follow a normal euthymic period and then follow with a depression. It could be any combination. It could be depression, and then mania, or mania, couple of episodes of mania, and then depression, Or you may only have a manic episode. You never have a depressive episode. It's still diagnosed as a bipolar disorder. So the mainstay of the bipolar disorder treatment is the mood stabilizers, and the most established mood stabilizer is lithium salts. And then there is the valproic acid, is Depakote here, but the generic name is valproate or sodium valproate, valproic acid, essentially the same molecule. Then there is Tegretol, or Lamictal or lamotrigine, generically trileptal or oxcarbazepine, carbamazepine, which is Tegretol. So there are many mood stabilizers, but in many cases, if there is a predominant depression, you would have to add a little bit of an antidepressant. So you don't want to overwhelm the patient with an antidepressant, because in some cases that can trigger a manic episode. So the mainstay, the foundation, is a mood balancer, mood stabilizer, along with just a little fine tuning, adding some, we use nowadays atypical antipsychotics. The antipsychotics are typically classified into two broad categories. The first one is our conventional antipsychotics, or they call it a first generation antipsychotics or traditional antipsychotics. They are in the chlorpromazine category, chlorpromazine, trifluothiazide, haloperidol, perfenazine, those types of antipsychotics. And the newer generation, or the second generation antipsychotics, the first one was risperidone, then aripiprazole. Actually, the most effective medicine for severe bipolar disorders that border on psychotic. They call it schizoaffective as well. It's a combination of some thinking disorder and affective disorder. So it's probably in between bipolar and schizophrenia. The most effective medicine is clozapine. And in fact, just as an aside, I have had two patients that, in my memory, they were people from India that immigrated to the United States, whose son had a severe schizophrenia, that came to see me. And although United States is very advanced in treatment of schizophrenia, and they introduced clozapine, which is the most effective treatment for chronic schizophrenia, it's very hard to implement that medicine here in the United States nowadays. And the hospitals do not keep patients here more than a week. So I told the parent that the treatment for your son here in the United States is there's just no effective treatment available here, except in very, very few fine hospitals in very few states. So I recommended that they take their son to India. And the place that I recommended, that I knew then, was the Bangalore Institute of Mental Health. And I recommended this clozapine, and I still see that father now and then, and the son has been living in India and doing very, very well on these medicines. There are two other patients that I recommended that medicine in India, because India, Indian psychiatric hospitals are able to manage the acute psychiatric patients, in my opinion, a lot better than hospitals here in the United States. For the severe cases, whereas for the mild cases, I would say there is a lot more acceptance in the United States for accepting treatment. So the essential answer to the question is the mood stabilizers, such as lithium, valproic acid, carbamazepine, oxcarbazepine, that type of medicines, along with antipsychotics and some depression, but they are more adjunctive medicines, not the primary medicines. Any other questions?
Yes, sir. The next question is from Huria. The question is, sir, can you give some suggestions for fearing of stress in a live-in relationship?
Say that is stress in a what relationship?
Live-in.
I'm sorry, I didn't get the type of the relationship. I
The live-in relationship, sir. Living in together.
Oh, you know, I have to admit that you have to find out who is the source of the difficulty. So you have to. I mean, these interpersonal relationships, the minor psychiatric symptoms present more in interpersonal relationships. For example, patients who have what they call hypomanic personalities, or hostile personalities, or mild paranoid personalities. These symptoms do not present in their social networks or in a work environment. So people might perceive the individual as a fine individual, very helpful individual outside of a close interpersonal relationships, and the bulk of the stress is experienced by the spouse or the close people around the individual that is the source of the problem. So you really have to find out the dynamics or the problem individual. So I don't know if there is a bad chemistry. There may be some, but my thinking would be to figure out who is perceiving things that should not be perceived, who is overly sensitive. And once you find that out, if the patient is able to admit that this is something that they need to fix, once you fix that problem, along with some therapy, once that is fixed, they can grow in that relationship. But until the psychopathology is identified in whoever is contributing to that problem, it'll be just a guessing game.
Thank you, sir. So the next question is from your friend Gopakumar.
Okay.
I will quote his words. In one of our abnormal psychology class, Dr. V.K. Alexander sir was telling that he uses psychotherapy to console the mentally ill people, and at times he used to give only some vitamin tablets. I do not remember which type of illness he did it for, but don't you think that creating confidence in the patient, like creating a rapport, is more important than prescribing medicines?
Yes, absolutely. Goban, I used to come and see you, but for some reason I lost your number, and I tried to call you many times, and I even asked Jose, who passed away, our friend, but he said that he didn't have any contact either. So I finally gave up. So I'll make sure that I come and see you next time I come. In fact, I was supposed to come this year, but because of the COVID, obviously nobody is traveling. So Very, very nice that that you're there. So extremely important is rapport. See, the rapport is established when a patient realizes that the doctor knows the extent of the symptoms. For in my case, for instance, for me it takes maybe 10-15 minutes for a new appointment for me to figure out and to prescribe the medicine. So how can you establish a rapport in 15 minutes? The way I have found is there may be some time element involved, but the patient knows when in that context, when the doctor asks the questions, the patient knows that the doctor truly understands the extent of the distress. So, for instance, a mother comes to me very distressed because I'm just being an extreme example. One of their relatives or their children had an accident or some other very unfortunate event. Now, there is no point in me crying with the patient, but I still need to understand the extent of that mother's distress. And if I begin crying, then I lost my ability to be able to technically help the patient. So my task is to convey that feeling of understanding, which leads to that rapport, by giving her, asking her the questions, and to in a manner that I would technically analyze the full spectrum of her symptoms. Is she having trouble with their appetite? Is she having hopeless thoughts? Is she, to the extent that she now wants to join the sun, so to speak, or is she having trouble sleeping? Is she unable to eat at all? And the fact that the patient comes to you for help itself is a sign that the patient is trusting. Unless it's a paranoid patient, obviously they never come for therapy or treatment on their own. They come because of pressure from their spouses or the family. So there's a family problem. Typically the wife is very unhappy, and the family puts pressure on the patient, and the patient is brought, and the patient comes in to please the family, not seriously realizing that the patient has the problem, and the patient would be more eager to tell me what's wrong with the wife or wife's family or his family, depending on the situation. So the rapport is an unwritten, it's a feeling that you get, and some people are able to establish rapport rapidly, and it has to deal with the tone of voice and the manner of the words that you use, whether the patient feels that connection. And if I could say this myself, I could easily identify, feel a rapport with the patient in very, very few minutes, because you know the field, and you know how to ask the questions. And fortunately my tone of voice is soft. It's not a threatening tone, and it's the way you come across. And you don't have to laugh with the patient, you don't have to cry with the patient, but if the patient understands the doctor is focused on your problems, the doctor is clearly seeing the extent of your problem, and that's very important, because you have to differentiate between a minor situational disappointment related depression, or a minor demoralization related depression, and a morbid depression or severe depression that can lead to hopelessness and thoughts of wanting to take your life or other people's lives. So you have to make that diagnosis, and 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 to give you another example, um, I see rapport as important, but for me, a little more important, especially with teenagers who are not very introspective. I put a lot more emphasis in collecting the collateral information from their parents or their teachers. So even if the teenager says, well, I want to be here by myself, I usually don't allow that. I said, you can tell me what you want to say, but I want to hear from your parents or your uncle, because I would rather get the facts, and the rapport will follow. That's been my experience. Um, so, but in therapy, it's a little different, because in therapy, unless you get the report, the patient is going to say, well, that doctor really didn't want to listen to me. Uh, but ultimately, the psychologist has to confront any irrational interpretations or thoughts, but you have to do it in a way that the patient will say, well, the psychologist, the therapist is not agreeing with my thinking that it's my wife that's causing problems, or my brother or my father. So ultimately, you have to find ways, but in paranoid cases, it doesn't matter how long you spend time. They're going to they're going to stop therapy once they realize that that the therapist is trying to put a different perspective into their thinking, because they're usually the paranoid thinking is so entrenched. It's very, very hard to treat those cases, and mild paranoia is a very serious problem in Kerala that's being undertreated. That is the basis of a lot of family problems, and especially interpersonal, because the mild paranoia only presents itself in close interpersonal relationships, because people lose their inhibitions, especially in a marital situation. They lose their inhibitions, and that's when the psychopathology expresses itself. Whereas in an outside environment, they are more guarded, and so it's like being in a marriage. It's almost like having a few drinks, because their inhibitions are less. Whereas outside, they're more guarded. They're not going to show their controlling or hostile or paranoid tendencies, and that's just a difficult problem. And I've had many calls. So what we are able to do in Kerala is, and in this particular case that I remember, they would put the liquid form of haloperidol, very low dose of the liquid form, in the coffee, and the patient gets better. But the problem is, if there is an extrapyramidal side effect or a problem, then the patient becomes more paranoid. So that's a very difficult process. But sometimes you got to use some tricks to help people. So it's a lot better than going through a serious marital problem and having a very sad life. And in our society, remarriage and everything is just so stressful, especially on the woman. So you just do your best you can to help with the situation, even if you have to use some tricks. So Govind, I'll definitely come and see you. In fact, Dr. Sina, please feel free to share my number and my email with anybody that wants to contact me and consult with me on cases. I'll be happy to help.
Thank you, sir.
I have time, so if you want me to keep going, I will. So you tell me.
Yes, sir. I will tell you the next question.
Okay.
The next question is from Sainamis, our head of the department. She has asked, sir, can you please discuss treatment of personality disorders, both psychotherapy as well as medication?
Okay. Now, I wrote this book on personality disorders that was written in 1998. I'm just going to show the audience this. Can you see the book?
Yes, sir, we can see.
Okay. So, although at that time, this is 1998, there were hardly any discussion of treating personality disorders using medications, and that is the focus of my book, and that was published initially by Haworth Medical Press, and now they're republished by Routledge in London. Just last year, they republished it. The personality disorders in the DSM-3. But by the way, I don't look at DSM-3 because it doesn't really help me treat a patient because I value enumeration of the symptoms to pick a medicine. So there is no medicine, for instance, histrionic personality disorder, or dependent personality disorder, or borderline personality disorder, or antisocial personality, schizoid personality, schizotypal personality. So the symptomatology is all on a continuum. So what they call axis 1 diagnosis, like major depression, schizophrenia, bipolar disorders, OCD, panic disorder, generalized anxiety disorder, and personality disorders. The only difference is when they say personality disorders, they imply these are chronic, enduring symptoms that kind of defines a person. Oh, that person is always hyper, or so there's a new category that they were proposing, hypomanic personality disorders. So these are all on a continuum. In fact, there is no brain area that is responsible for personality disorders. There is no other brain chemistry that is responsible for the axis 1 disorders. So the thing to do to simplify it from a medication standpoint is to describe the specific symptoms that the person is experiencing. So if it is schizoid, it involves social shyness, social withdrawal, social avoidance, and too much autistic, that means self-centered preoccupation. And autistic thinking can also mean peculiar type of thinking that is very internalized, is also called autistic thinking, as well as, say, for instance, schizotypal personality, which is essentially eccentric tendencies. So these are, when you look at the neurochemistry, these are milder forms of irrational thinking. So from a medication standpoint, which is my focus, would be low doses of either typical or atypical antipsychotics. Now, when you use atypical antipsychotics, the atypical antipsychotics, an example would be risperidone or aripiprazole or olanzapine. Now, they do not address the positive symptoms of psychosis. For example, eccentric thinking, irrational thinking, or hostility. One of the other symptoms of psychosis is extreme rage, for no reason, or extreme bitterness for no reason. So rage itself is a psychotic symptom that needs to be addressed, because it is usually totally out of proportion to an event. So even if somebody is triggered into an anger, if the level of that anger is way disproportionately high compared to the occasion, it's a psychotic anger. And that's when they lose their judgment and hurt other people, or hurt themselves, or destroy property. And that needs to be treated. And for that purpose, the traditional antipsychotics typically work better, whereas the atypicals have a little bit of an antidepressant effect. So in some cases, when they use atypical antipsychotics, for instance, low doses of aripiprazole or risperidone, sometimes you see a paradoxical worsening of their agitation. So again, these things you cannot totally predict. I'm just giving you generalizations. So my answer to the question is, from a therapeutic, from a psychological counseling standpoint, the focus would be perhaps using cognitive behavioral therapy to get the patient to be able to understand their own tendencies towards a peculiar way of thinking. But if they still have schizotypal symptoms or schizoid symptoms, they are very hard to overcome by counseling alone. They would need some medications, perhaps lower dosages compared to treating a schizophrenia. Whereas if somebody has social anxiety or performance anxiety, stage anxiety, they call it by different names, or flight phobia. Obviously, you can use techniques like relaxation training or desensitization training, but occasionally, especially in stage fright or flying phobia, this surge of anxiety is so intense that that any amount of breathing training, desensitization, is just not enough to hold that surge of anxiety from breaking through. So you need just a very low dose of what they call a benzodiazepine or alprazolam. I think in India it's called Alprax, just for temporary use, just for 1 or 2 times, because they are addictive medicines, so you don't want patients to stay on them. But the therapy helps with personality disorders to gain for themselves insight. And by the way, a person gaining insight makes them more introspective, so they become almost like their own therapists once they reach that level of awareness. So they can then control themselves to some extent. For instance, somebody is very prone to anger towards their wife or children. If they are taught to be introspective, they are able to some extent, control that anger. And if the anger still breaks through, obviously they would need some medications, because a person who is overly angry, it's a stress on that person himself, but it's also a stress on people that have to live with that person, especially close relatives, wife, children, husband, relatives, are walking on eggshells around that person. And that's also a sign that there is a serious problem. So if you get these vibes when you talk to a patient, if the therapist or the psychiatrist feels this uneasiness, we call it a vibe, and that itself is a clinical clue that the patient has serious problems. So personality disorders, I don't look at the specific personality disorders because there's no really medicine for one personality disorder versus the other. It all has to do with the symptoms. So I think, when I came to India, I left, I think, some copies of my books at the UC College library. Read the first chapter in my book where I explain the rationale for treating the personality disorders. In fact, I'll tell you right now, in my first chapter where I describe the general clinical context, I think it is about 44 pages. Let me see how many pages. That where I outline my rationale for using medications. Okay, so it is 23 pages of rationale for treating the personality disorders. And then I go into each personality disorders and how to decipher the symptoms. Now, this is from a medical standpoint, from a medication picking standpoint, and I've given specific dosages as well. So it's a very clinically applicable book, and I don't know how much it would be useful to psychologists. But the thing is, psychologists work closely with psychiatrists. So most patients who come for psychotherapy and counseling are typically also on medications. So it would be important for a psychologist to understand the medications to some extent, and also sometimes to recommend. I've had therapists who are very clinically astute mentioned trying out a medicine, and then I would always comply with that and try it out. So that book explains, and I'll bring more copies if you like. Not that my book is the only book, but I should, again, if I could say this myself, the medication treatment of personality disorders that I published in 1998, and only because they found that the book is still applicable, did the new publisher want to take it on and republish it again in exactly the same book, but with a different cover to it. And that was one of the very first books in the management of personality disorders using medication. So in my clinical practice, I hardly ever diagnose the personality disorders because for me, everything has to do with the symptoms that I can relate to the brain chemistry, and I treat them as if it is an axis 1 disorder. So the DSM can change again and again and again. I don't need to change it because there is no reason for it. And one other thing that I would like to mention that I wrote down is the new approach. I've heard that some of the Indian psychiatrists, by the way, they are very good clinicians. We are all from the same background, so there's nothing make somebody just coming to the United States any better than any doctor in India. But there is a tendency for the pharmaceutical reps and the medical equipment reps to promote, and the supplement reps to promote the supplements and what I call gimmicks like brain scans and gene testing in psychiatry. It's just to me, it's just a way for them to make money. I don't want to sound paranoid, but psychiatry is still, and psychology is still a clinical field. There is no neurochemical test that reliably will tell you what the illness that the patient has, or to choose the medications. So why would somebody spend, I would say in rupees, maybe 20,000 rupees in a brain scan, or 20,000 rupees in doing a gene testing, or they call it genetic testing or gene testing. And these gene testing companies, they took a salival swab and go through the analysis, and they spit out 3 pages of report saying this patient will benefit from this medicine. It never works. The patient loses the money, the family thinks that this is great, and the magazines promote it, the ads promote it, and probably the doctor gets a significant incentive to recommending that. But psychiatry remains, in my opinion, a very clinical field. So, I have never been impressed with having the patients spend so much money on these extraneous tests, where a good clinician can just interview the patient and a family member, usually a spouse or a husband, along with the patient, and figure out within 10-15 minutes at the most the crust of the problem, without costing a lot of money. For many of the patients are very poor, and especially I would think in Kerala, where there is no insurance coverage. So just be aware of that. This is my personal opinion, and the doctors here also do that. I don't believe in it, and for good reasons. And obviously, drug companies and equipment companies and the reps have to make money, so I'm sympathetic to their situation. But my obligation and allegiance is to the patient, to get them better with the least expense as fast as possible, and improve their quality of life, not only for themselves, but also people that have to live with them. Can you imagine living with a mildly paranoid patient? It's a nightmare. There is no happiness. You're always on edge. It gets the other family members nervous, depression, anxiety. It's an unhappy life. So the earlier you diagnose and confront that and persuade the patient to get the treatment, the better for the family. And I think, especially in Kerala, that's a tremendous problem. Underdiagnosed oversensitivity, underdiagnosed overperceptiveness that borders on slight paranoid or slight manic tendencies, where typically the males, I have nothing against males, but that's the tendency that I find, that overspend, live beyond their means, especially when there is such social mobility in Kerala in these days, where people are very much involved in the technology, Facebook and things of that nature. Having studied in one of the most highly technological universities, that's MIT, I don't go into Facebook or Twitter or none of that stuff. I just know how to use the internet, the computer, YouTube, old songs, and soccer and preventive medicine. And by the way, I didn't touch on the preventive medicine. If I have time, just for a few minutes, I could touch on that. And if you have other questions, please feel free to bring up. One of the main problems among Indians is what they call is abdominal obesity, which makes them very susceptible to what is known as type 2 diabetes, hypertension, and lipid cholesterol problems that causes atherosclerosis, that's hardening of the coronary arteries, and stroke. So there's a lot of people who succumb to premature heart attacks, and strokes. And this is easily preventable. So what I have been recommending to people, by the way, although I'm a psychiatrist, I have the full medical degree, and I have a special interest in preventive medicine, and I apply that to my own life. So I encourage people to and to limit carbohydrates. That means limit rice, 2 tablespoons of rice, more curry, whatever curry you like, less of the fried grain-based food. For example, masala dosa, puri, they are fried foods um, that use a lot of the grains, to limit them. So when you go out, eat maybe half masala dosa. You don't have to avoid the foods, but limit these types of foods and eat more lean protein. That means more curry, more pure vegetables, not potato, and less fruits. Uh, Again, fruits are good, but in excess, they give a lot more carbohydrates. And among Indians, the tendency is to gain weight in the abdominal area. It's known as visceral obesity, and that is a toxic obesity, because that makes the among Indians more susceptible to type 2 diabetes, and then that leads to the accelerated atherosclerosis, and that leads to heart disease and stroke, and there's a lot of premature um, deaths. So, and in addition to that, aerobic exercise, not weightlifting, not building up muscles, but aerobic activities that is involved in light jogging or fast walking. But the trend that I have seen in Kerala nowadays is to limit physical activities, physical play, sports, and people are more into watching TV. Obviously, I was fortunate in my days; there was no TV. So, but those activities, learning all those the extracurricular activities, give people coping skills. So if you face with a disappointment in life, and I have faced many disappointments in life, setbacks, you go and do a 20-minute jog outside in the sunlight, whether it's daytime light, or go play a little soccer. Find a friend and kick the soccer ball, running up and down the field, or play some tennis, or listen to some music or something. It gives them coping skills to cope with your day-to-day major stresses or setbacks. And I think that may be lacking now, because people are tuned into TVs and serials, and computer games and internet. So I would encourage young people to limit those things and to learn some interest in playing some musical instruments, learning some music, and or more importantly, involved in some physical activities like badminton, some simple games that do not require a lot of space, or even shuttlecock. It doesn't take that much space, but it gives very good exercise. So when you have a setback, you go play a game of shuttlecock, like for half an hour, get nice and sweaty, and you take a shower. It gives you a good feeling. The burden in your mind before the game is not as much after that game, because then you're not only interacting with another human, or depending on, say, volleyball, you're interacting with 5 or 10 people. It just lightens the load, and you feel like the problem that you had initially is not as heavy as it was before the game. So these are social coping skills that are as good as therapy or medications, perhaps even better for you from a longevity standpoint. So and so if people want to get into that health focus, because we have one life to live, you want to be as healthy as possible to enjoy this one life that we have, go to your doctors, ask them to check your, say, A1C test, which gives an average blood levels for the last 2-3 months. Get your lipids, that's cholesterol, LDL, HDL, triglycerides, check your blood pressure, and they all need to be treated. The latest recommendation is to bring the blood pressure to systolic 120 over diastolic 80 or less. So the old concept of, well, you're growing old or you're growing older, and a systolic of 140, 150 is okay, is no more valid. And I read up on, and again, some of the things, I'm going to say, I don't have to keep saying, if I could say this myself, but I read up on all those, all the latest on cardiology, endocrine, metabolic diseases. Although being a psychiatrist, I read up on all those things, because when you go into medicine, if you cannot apply the knowledge of human body in your own life and help other people with that knowledge, whoever who would listen, what good is medicine? So you cannot be a good doctor and hate medicines. You have to believe in medicines. You have to believe in the physiology, why medicines act. And the same is true with Ayurveda or homeopathy, who believe in that. So, but my focus is on, the allopathic medicine, which is my specialty. And then that's what I believe in, because it's based on physiology, neurochemistry, anatomy. It makes a lot more sense to me. So I would encourage people to do that rather than, and the doctors in India, they're elegant doctors. Like I said, a doctor who come to the US doesn't become a better doctor because it is the same Malayali. If I can use an expression in Malayalam, I don't know the English expressions for that. നമ്മൾ പറയും കാക്ക കുളിച്ചാൽ കൊക്കാവൂല. അതിൻ്റെ അർത്ഥം, നമ്മൾ എത്ര മലയാളി എന്ന് പറഞ്ഞിട്ട് ഇവിടെ വന്നു കഴിഞ്ഞിട്ട് നമുക്ക് ഒരിക്കലും സായിപ്പാവില്ല. We're always Malayalis. Our identity remains Malayali at the core. നമുക്കിപ്പോൾ ഇംഗ്ലീഷ് പഠിച്ചു, അത് പഠിച്ചു, ഇത് പഠിച്ചു എന്ന് പറഞ്ഞിട്ട് നമ്മൾ സായിപ്പാവില്ല. അപ്പോൾ നമ്മുടെ നാട്ടിൽ പ്രഗത്ഭരായിട്ടുള്ള ഡോക്ടേഴ്സ് ഉണ്ട്. പക്ഷെ ഒരു കാര്യം ഞാൻ ശ്രദ്ധിച്ചിട്ടുള്ളത്, അവർക്ക് ഇൽനെസ് ട്രീറ്റ് ചെയ്യാനായിട്ടാണ് പലർക്കും, എല്ലാവർക്കും അല്ല, ഇൽനെസ് വന്നു കഴിഞ്ഞിട്ട് അവർ ട്രീറ്റ് ചെയ്യും, നന്നായിട്ട് ട്രീറ്റ് ചെയ്യും. പക്ഷേ നമുക്കൊരു പ്രിവെൻറ്റീവ് മെഡിസിൻ ഓറിയൻറ്റേഷൻ ഉള്ളവർക്ക് ഇൽനെസ് നമ്മുടെ ലൈഫിൽ വരുന്നതിന് മുമ്പ് തന്നെ, കാരണം അതിൻ്റെ ഡാമേജസ് ഓൾറെഡി വന്ന് തുടങ്ങും. ഇപ്പോൾ type 2 ഡയബറ്റീസ്, ഇപ്പോൾ hemoglobin A1C below 6 is considered normal. But actually, the microvascular damage begins at an A1C of over 5.0. So even those who are in a normal range, which is probably 5.4, 5.6, 5.7, they are still susceptible to the damages that keep occurring over a period of 10-15 years. So somebody who has an A1C of 6.5, which is when many doctors would begin their treatment, the damage is already done. So I am sharing with you an insight and knowledge that I apply in my own life. If I could be, and I don't mind, I decide to take myself metformin. And although I don't have type 2 diabetes, my A1C is 5.4, I want to bring it down to 5.0 because not that my life is any more important than any of your lives, but God gave me these opportunities, not because of my own abilities, but my circumstances, my parents, and the timing and luck gave me these opportunities. So I try to apply that not only in my own life, but I try to encourage my friends and my friends that know me that will tell you. I try to help them out to be proactive. And so this is something that you can talk to a doctor who is a little progressive, but I would avoid spending too much money on the supplements because they are not proven. And there is a tendency among Indian doctors to prescribe a lot of supplements. You want the real medicines because they have real pharmacological benefits. The supplements and alternative approaches are based on faith. Faith is okay. So another example I've always liked that I like to use is so when you have a big test coming up, and the student wants to pray a lot for the test, so I try to encourage them, pray a little bit but study really hard before the test, and once the test is over, then you go ahead and pray 24 hours. Because if God really wants to listen to the prayer, he can listen to the prayer and grant you your prayer even after the test. But you can't give up studying and pray before the test to be able to do well in the test. It's a very practical approach that I use. So and a similar approach to medicine, to do the best you can ahead of time before damages already occur, then you can limit the damage from further progression, but the damage that's already done is very hard to reverse that. So just a little tidbit on preventive medicine. So if you have any questions on that, feel free to be more specific and I can go into details. But another thing that I do is we call it Gandhi soccer, right? It's peaceful soccer, no physical contact. And I manage that. We have people from all over the world, but they listen to our rules. And it's fun soccer. So anyway, that's anything else?
Sir, there are some questions which have not been answered due to lack of time.
Okay.
So we would forward these questions to you and you may respond accordingly, or else we have provided your email ID so that they may ask you directly.
Okay. I mean, do you want me to stay on and answer the questions? I'm okay with that, but that's up to you.
No, sir, we will forward the questions to you.
Okay. You want me to go over them now?
No, sir, we will mail it to you.
Okay. So I can take care of it at my own time. Is that correct?
Yes, sir. Yes, sir.
Okay. Well, I would like to thank you for this opportunity. First of all, I would like to thank Dr. Thomas Matthew. I don't know if you missed the first part. I would like to thank Dr. Thomas Matthew, who has been very active in the U.S. In coordinating the UCC Alumni Association. And even when I've been lax in responding to his email, he has kept up with that, and I truly appreciate that. I'd like to thank Dr. Sina, who was very interested and very active, and emailed me and called me many times, and Agilesh, who helped me set up these things, and Professor Saina. And I apologize if I forget anybody else. So thank you for this opportunity. So if you like me again at some point, maybe in a year, 2 years, or whenever, please call me, and I'll be happy to share my practical knowledge and recommendations in any of these fields that I believe I have some expertise. So thank you all very much, and it's a great opportunity for me to hopefully connect with some of my other classmates who I have not been in touch with, and I'm very happy that Goban was also a participant, and there may be others. So please feel free to contact me. I'm not on Facebook, but my cell number, you can use WhatsApp, or my email. Those are the only two social avenues that I use. I don't get involved in anything else. And thank you so much.
Thank you, sir. I would now like to propose the vote of thanks. A webinar series like this is a result of the hard work of a number of people. Dr. Sonny Joseph has contributed to our efforts by agreeing to be the speaker for this webinar and have given us a wonderful and informative session. Also, sir, I definitely feel that we should have another session with you in this series. I take this opportunity.
I'd be happy to. Well, I'll be honored.
Sure, sir. I take this opportunity to thank him wholeheartedly on behalf of this college, the department, and all the participants of this webinar. Thank you, sir. Next, I would like to thank the college authorities, our respected principal, Dr. David Saj Matthew, and our beloved manager, Reverend Father Dr. Thomas John, for their unstinted support for the conduct of this webinar series. I would also like to place on record the tireless efforts put forward by the teachers of our department, led by our head of the department, Ms. Saina Susan Abraham, and coordinator, Dr. Sina M. Mathai. Thank you, teachers. A special word of thanks to Agilesh for rendering all technical support. A webinar is only as successful as the participants make it. We were blessed to have more than 200 participants for today's webinar. They consisted of a mixed group of students and teachers from various colleges, research scholars, and practitioners from the field of psychology. I would like to convey our heartfelt thanks to all the participants who made today's webinar a great success. By the way, sir, your friends and classmates like Gopakumar, Dr. Rajan Mathai, Dr. Wilson were also part of the audience of this program. Thanking everyone once again. See you at the next webinar. Thank you, sir.
Thank you.